Welcome to the Epilepsy Discussion Panel. I'm Nathan Fountain. I'm Professor of Neurology and Director of the Comprehensive Epilepsy Program at the University of Virginia, and I'll be moderating today's discussion. This session will begin with 6 separately pre-recorded lectures for our topic experts. During the presentation, please submit your questions. We can get to as many as we can after the end of the lectures. It's now my pleasure to introduce our esteemed lecturers. First will be Dr. Mike Sperling, who's Professor of Neurology and Director of the Comprehensive Epilepsy Program at Thomas Jefferson University Hospital. Dr. Sperling is going to discuss ablation of small targets. Then we'll turn to John Ralston, who's Assistant Professor of Neurosurgery at the University of Utah and Director of the Epilepsy Surgery and Stereotactic and Functional Neurosurgery programs there. He's going to talk about fornix ablations and resective surgeries. Then Vibhor Krishna, who's an Assistant Professor of Neurosurgery at Ohio State University with a special interest in neuromodulation, epilepsy surgery, and focused ultrasound, will present his study about the treatment of epilepsy by ablation of the anterior nucleus of the thalamus. Then we'll turn to Dr. Robert Fisher, who's Professor of Neurology and Neurosurgery and Director of the Epilepsy Program at Stanford University. And he's got a big topic, a big bite to take, talking about existing neuromodulation therapies for epilepsy. And then we'll turn to Xiangyu Yu, who's Assistant Professor of Neurology at Yangming National University Hospital, and also Section Chief of the Epilepsy Section at the Neurological Institute of Taipei Veterans General Hospital, to discuss their Navifus system for treatment of drug-resistant epilepsy. And then we'll finish with Nathan McDonald, who's Professor of Radiology at Harvard Medical School and Associate Professor at Brigham and Women's, and has really been a pioneer in the preclinical development of focused ultrasound. And he's going to discuss low-intensity stimulation and microbubble studies as they might apply to epilepsy. So we'll start with Dr. Sperling.
Hello, today I'm going to talk about the ablation of small targets to treat epilepsy, an application for which focused ultrasound may be appropriate. Intractable seizures are treated by resecting an epileptic focus or an epileptogenic zone. Some types of surgery are done on relatively small lesions, spatially restricted pathological substrates, as I have written on my slide. And these include mesial temporal sclerosis, hypothalamic hamartoma, periventricular nodular heterotopia, small cortical dysplasias, small tubers in the setting of tuberous sclerosis, and cavernous hemangiomas. These may then be amenable to not only minimally invasive interventions like we're doing now with thermal ablation or radiofrequency ablation, but may be amenable to non-invasive interventions such as focused ultrasound. And this is what we need to consider, and this is where work needs to be done. In the best of all possible worlds, you would achieve similar rates of seizure freedom as performing open surgery or minimally invasive surgery. We might even accept lower seizure-free rates in exchange for lower morbidity and risk and discomfort. If the procedure is a lot safer, we might accept a lower seizure-free rate, reasoning that if we have to, we can go back and do additional ablations or do open surgery. Now, let me show examples of these few targets so you have an idea of what I mean. What you can see in this MRI scan, hopefully you can see my arrow too, but there's a big yellow arrow. This is a sclerotic mesial temporal lobe. The whole mesial temporal lobe is smaller compared with the contralateral side, and the hippocampus is substantially atrophied. You can see it on 2 slices here. So you have a normal hippocampus on one side and a small one on the other. This is a small target that right now we can tackle with thermal ablation, for example, and focused ultrasound may be amenable to this. This is another example. Now, this is probably not necessarily the sort of patient you'd want to do the procedure on, but it's an example of periventricular nodular heterotopias. In this case, the patient has extensive heterotopias on both sides. What some people have, however, is a single nodule or 2. And others have more extensive bilateral heterotopias, but the seizures can be demonstrated with intracranial EEG to come from one nodule. And then one, again, might try to tackle that with a minimally invasive technique or a non-invasive technique like focused ultrasound. This last picture that I'll show you is an example of a hypothalamic hamartoma. The arrow shows the lesion very nicely. It's a small lesion adjacent to the third ventricle, and open surgery is done in these, and it's not great. It has significant morbidity, and stereotactic ablation can be done, and focused ultrasound is also, I think, an interesting thing to think about for this. It tends to happen in kids. This is an example of what it looks like after you've done stereotactically aimed thermal ablation, in this case, a patient in our institution. So the patient had a probe placed. You can see the black line, that's the line of the probe. And then this is the immediate post-ablation MRI scan showing a sort of sausage-shaped lesion in the sagittal view on the left and the coronal view on the right, showing a nice mesial temporal ablation. Again, focused ultrasound might work nicely for something like this. In the published study by my colleague, Dr. Chen Wu, last year in epilepsy, while controlled data is not available, uncontrolled data is quite encouraging. And for over 200 subjects, 234 subjects actually, you can see average seizure-free rate at 6 months and 12 months is in the neighborhood of 60 to 70%. And it appears sustained out to 12 months with mesial temporal sclerosis in orange, and actually non-mesial temporal sclerosis in green for patients who had electrophysiologic proven seizures. So it's encouraging, and thermal ablation for cavernomas has published literature. It has it for hypothalamic hamartoma. It's encouraging as well. So I'll conclude by saying that we know that thermal ablation can effectively treat small discrete lesions when using a laser probe, and radio frequency has been reported to do it too. And we have, a variety of techniques available. The perioperative disability period is very brief. People are generally in the hospital for a day, have minimal to no pain within a day. The discomfort is quite modest. The morbidity appears to be less. The risk of infection is less than with open resection. And therefore, a less invasive technique like focused ultrasound, which would have also the potential for reduced morbidity, merit investigation for these techniques. And again, I would just emphasize the results may not need to equal the results of a resection, because less pain may justify less gain. Again, reasoning that you can go back and do more. I'll close with one comment, and that is that expense makes a difference. There are issues with insurers at present using the laser thermal ablation because it's more expensive than simply sending somebody to the operating room, even though the people are in and out of the hospital in a day and need no ICU stays and have no disability from work beyond a day or two. The expense issue will need to be carefully addressed with focused ultrasound as well, or else the technique might not be adopted. Thank you.
Hello, my name is John Ralston, and I'm the Director of Functional Neurosurgery at the University of Utah. Today, I'll be talking about the case for non-invasive epilepsy surgery. So here's my disclosure slide. So epilepsy is very prevalent, affecting about 1 in 26 people during their lifetimes. That means about 1% of Americans, 3 million adults, 500,000 children have epilepsy in our country. This severely impacts patients' lives. There's social stigma. It's difficult to find employment and keep employment. There's driving restrictions. But it's also not a benign disease. There's the phenomenon of sudden unexpected death in epilepsy, which can kill 1 in 1,000 people for normal epilepsy and about 1 in 100 patients per year for drug-resistant epilepsy. So not a benign disease whatsoever. Epilepsy, when we first are diagnosed it, we usually try treatment with medications. With that first medication, about half of patients can become seizure-free or have well-controlled epilepsy. If that first medication fails, we try a second, which might capture another 13% or so. But once we get beyond the second medication, the chance of a third, fourth, or fifth medication helping becomes very, very small. And this prompted the definition of drug-resistant or refractory epilepsy, which means when you fail 2 or more medications. This is still the case despite all the new plethora of anti-seizure drugs we've developed over time. Many of these have better side effect profiles, but they haven't changed that phenomenon of drug-resistant epilepsy after failing 2 medications. So again, the ILAE definition of refractory epilepsy is the failure of 2 or more medications when well tolerated, and about 1 in 3 patients with epilepsy has drug-resistant epilepsy. So what do we do for this? There are now 3 class 1 studies, 3 randomized controlled studies showing that surgery is better than continued medical management for patients with drug-resistant epilepsy. The first was the landmark study by Sam Beebe in 2001, published in the New England Journal. That was followed almost a decade later by the early surgery study by Jerome Engel, the ERSET study in JAMA, and then another one more recently about pediatric surgery specifically. Now, all of these are showing that about a long-term follow-up 1 year later, about a 60 to 70% cure rate or seizure freedom rate for these patients. They also all show significant quality of life improvements, and there's a lot of data showing that these effects are durable over time. The number needed to treat for epilepsy surgery from this data set is 2. And that compares to something like oxycodone for pain, which is a number needed to treat about 6. This prompted Jerome Engel in 2003 to get this quote, which says that surgical treatment for epilepsy is arguably the most underutilized of all proven effective therapeutic interventions in the field of medicine. This also prompted a joint guideline set from the American Academy of Neurology, the American Epilepsy Society, and the American Association for Neurological Surgery that says that medically refractory patients or patients that are diagnosed with drug-resistant epilepsy should all be referred for epilepsy surgery evaluation. So now that we know how great surgery is and what a simple definition for drug-resistant epilepsy is, what do we think the average time it takes for someone to get one of these referrals is in our country? 20 years is the answer. So the time that someone is diagnosed with drug-resistant epilepsy to the time they're referred for surgical evaluation on average for adults is 20 years. The rate of surgeries hasn't changed over time despite all these randomized controlled trials and major publications. And partially this is due to patients being afraid of the surgery, afraid of death or memory problems or complications. Another part of this reason for the long delay is that the physicians that are referring these patients don't necessarily know the definition of drug-resistant epilepsy or who are good candidates and what the risks and benefits are for surgery. So what do we do about this? The first thing we can do is education, so trying to do outreach to both patients and community physicians and referring physicians to tell them the utility of epilepsy surgery and the risks to continuing medication management. But probably a more important thing is to change that risk-benefit ratio for surgical intervention to make the risks lower and the benefits greater. Anything we can do to change that calculus will help encourage more patients to come visit us. And we're already doing a lot of things like that. So laser ablation is a good example of a minimally invasive epilepsy surgery, which is very attractive to both patients and referring physicians. A stereo EEG compared to open grids is also more appealing for a lot of people. But there might also be a role for focused ultrasound. In our movement disorder practice here at the University of Utah, we've seen about a 40-to-1 increase in referral patterns for focused ultrasound treatment of movement disorders compared to contemporary deep brain stimulation. There just seems to be a large population of patients that does not want a hole drilled in their head no matter what, and is looking for some incisionless sort of therapy to treat their diseases. So how could focused ultrasound be used for epilepsy? Our idea here was to look for a centrally located region in the brain, which is good for the sort of transduction of these ultrasound beams, that was small and compact, that could ameliorate the symptoms of temporal lobe epilepsy. So for us, we thought of the fornix being a good location for this. It's small, compact, centrally located, surrounded by CSF, making it more or less safe. And we had this idea and thought, I wonder if anyone else has had this. So we looked back in time and found that, yes, even in the 1950s, people were performing fornicotomies, so lesions of the fornix to treat epilepsy. And recently we looked at all these studies that have been published and found about 136 patients with fornicotomy and about a 60% improvement in seizures or 60% responder rate to this. So it seems to have some sort of evidence that it might work. Right now, we're doing this preclinically in canic acid-treated rats, doing a focused ultrasound fornicotomy for these rodents to see the effect on seizures before we take it to the next level of a clinical application. And this is work done in combination with Dennis Parker, Karen Wilcox, Matthew Alexander, Allison Hay and Henrik Odin, and Karina Cornelson, which is one of our very talented graduate students. And with that, I'll share my acknowledgments, and I hope everyone the best.
Hello, I want to thank Focused Ultrasound Foundation for this opportunity to present. I'm Vibhor Krishna. I'm an assistant professor of neurosurgery at Ohio State. Today, I'm going to be sharing with you our experience with the anti-nuclear ablation focused ultrasound trial. We'll be presenting the anatomy of anterior nucleus, the rationale for anterior nucleus ablation, the trial design, eligibility criteria, the outcomes, and finally the current status of the trial and some concluding remarks. Anterior nucleus is a part of the dorsal thalamic nuclei, which is very close to the ventricle. And the fornix lies dorsal to the anterior nucleus. In a sagittal view, anterior nucleus sits right on top of dorsomedian nucleus, which is a larger thalamic nucleus. The mebelothalamic tract ends up in the ventral part of the anterior nucleus. And this part is rich in GABAergic neurons and is supposed to be the therapeutic target for neuromodulation. Anterior nucleus DBS is FDA approved for the treatment of treatment-resistant epilepsy. In the Santé trial, after placement of deep brain stimulation electrodes without stimulation, the seizure frequency dropped by roughly 20% in patients both who had the stimulation and the control group. In the stimulation group, when the stimulation started, the frequency of seizures further dropped to a total of 40% at 3 months, while in no stimulation group, it remained still suppressed at 14.5%. Roughly 50 to 60% of patients with antenucleus DBS experience this microlesion effect, and the duration has ranged from 4 weeks to 3 years. And this microlesion effect forms the basis for thinking about ablation as a potential treatment for treatment-resistant epilepsy. Within the antenucleus, again, the ventral part of antenucleus seems to be the site for effective stimulation in patients after deep brain stimulation. In the focused ultrasound trial, we are enrolling patients who have partial onset of epilepsy with secondary generalizations, who have failed at least 2 medications. And these patients have high seizure frequency, more than 4 seizures a month. And there are other inclusion-exclusion criteria related to previous workup, stability of their medication dosage, identification of antenucleus on MRI, willingness to maintain the seizure diary, and an involved healthcare provider. The exclusion criteria include low seizure frequency, unable or unwilling to maintain the medication dosage stable, indwelling vagal nerve stimulator, previous history of corpus callosatomy, generalized onset seizures, post-infectious epilepsy, history of drug abuse or alcohol abuse, neuropsychiatric disorders, severe developmental delay, and pregnancy. The primary endpoint for this trial is safety at 3 months, since it's a phase 1 clinical trial, and safety is derived based on neurological assessment, neuropsychological assessment of language, memory, and executive functioning. Secondary outcomes include seizure reduction and imaging outcomes, which are related to the lesion in the antenucleus on diffusion MRI and functional MRI. The study oversight is provided by the Data Safety Monitoring Board. We are allowed to enroll 10 patients, 1 plus 3 plus 6. Currently, we have enrolled and treated 2 patients. We haven't witnessed any serious adverse events. 1 patient had a decline in verbal learning, which was immediately present and was even persistent at 6 months assessment. Detailed neuropsychology assessment for the second patient is pending. As far as the seizure frequency goes, there was significant reduction in seizures in both patients. Patient number 1 has not had seizures up to 1 year after the treatment. And in second patient, the seizure frequency is reduced from 3 to 4 seizures per day to 3 seizures in 1 month. This is an example of the antenucleus lesion on T2 weighted image at 1 day, the diffusion MRI at 1 day, showing a central area with very high changes in restricted diffusion, surrounded by a periphery which likely represents the vasogenic edema. T2 weighted image at 3 months showing almost complete disappearance of the lesion, while diffusion MRI showing persistent changes even at 3 months. So overall, this is a trial that we are intending to address a large unmet clinical need where there are no effective medication treatments. The challenges that we have encountered are related to patient reliability, specifically being able to maintain a communication with potential patients through phone or email. There are competing treatments available like intranucleus TBS or laser ablation. And then the goal for the trial is to test for seizure reduction while not seizure freedom. And so this is an important distinction. And finally, overall, given the experience we had with 2 patients, we are cautiously optimistic that we should be able to test the treatment, test its safety, and to be able to address a large unmet clinical need in future. I thank you for your attention.
Thanks for joining. Today we're going to talk about one of the potential competitors to focused ultrasound as a new treatment for epilepsy, and that is neuromodulation. I'm Dr. Robert Fisher. These are my disclosures. I was a consultant to Medtronic. I led their deep brain stimulation trial, and Stanford received a grant from Insightec for a clinical FUS trial in epilepsy. About 1% of the world has epilepsy. Approximately 2/3 of these people can be controlled with existing medications, but that leaves the 1/3, which is a large number of uncontrolled people, greater than all these conditions that you see on the right side of the slide. So epilepsy is not a solved problem. Here are the general ways we treat epilepsy. Most people are treated by one of the 26 available medications, and some may be candidates for surgery to remove the seizure focus. Children and a few adults sometimes get the ketogenic diet. I practice in California, so many patients are on alternative therapies. Biofeedback has been recommended by some, but has little controlled evidence. And then we come to neuromodulation, which is changing the landscape of treatment in epilepsy. These are the sites that have been tried for neuromodulation. The ones in red have had controlled randomized trials leading to FDA approval in the United States. The first was vagus nerve stimulation. Stimulation of the left vagus nerve in the neck feeds impulses into the brainstem and the reticular activating system. So I suppose you could say that what happens in Vegas doesn't stay in Vegas. Sorry. Next came stimulation of the seizure focus with responsive neurostimulation, which puts a small EEG machine and stimulator into the skull. It senses seizures and it gives, air quotes, countershocks to stop the seizures. It also probably has a neuromodulatory effect between seizures. The stimulation of anterior nucleus of thalamus for epilepsy trial bilaterally stimulated anterior thalamus to modulate and disrupt the network that initiates and propagates mesial, temporal, and frontal seizures. So we have 3 neuromodulatory methods. How do we choose? This is one way, the unblinded single-tailed test, but most clinicians would go with efficacy and side effects as a method. Here is the efficacy in terms of percentage seizure reduction compared to baseline for the 3 modalities in the pivotal clinical trials. There is a somewhat unproven sense that RNS and DBS may be a little more effective than VNS, but there's been no controlled head-to-head comparison. It is interesting that seizure reduction continues to improve over time, so that by 3 to 5 years, you may be as much as 2/3 reduction or better, and 15 to 20% of people might remain seizure-free for at least 6 months. However, it is palliative, not curative. This simplified version of side effects indicates that VNS affects mostly the voice. RNS is well tolerated once you get past the initial surgical implant stage. DBS might cause transient depression, memory problems, or increase seizures if the voltage is too high. An important question is whether it would be necessary for FUS to produce a lesion in order to benefit seizures. We have an example in the past from radiosurgery. Animal studies indicated that low to moderate doses of radiation could be neuromodulatory against seizures. Unfortunately, neuromodulatory 18 gray doses didn't work well in a couple of clinical trials, and it required 24 gray in a study, including my co-panelist, Dr. Fountain, to improve seizures. Hopefully, this would not be the case with focused ultrasound. So in conclusion, neuromodulation avoids tissue destruction and preserves neurological function. It can be done in stages and it's adjustable. It's possible to do with bilateral seizure foci. Surgery is not. If it fails, resective surgery is still on the table. So FUS to create lesions to obliterate a seizure focus would be very useful. However, FUS to modulate a seizure focus without causing tissue destruction would be revolutionary and a completely new paradigm. Thank you for listening.
Hello, everyone. I am Shangyu Yu from Taipei Veterans General Hospital. I'm happy to be here and introduce our study of neuromodulation on epilepsy by using NaviFus. Our study was sponsored by NaviFus. I have no other conflict of interest related to this talk. Low-intensity focused ultrasound had neuromodulation in animals' epilepsy models. However, the safety and the effect are not well established in humans. In our previous study, we delivered FUS to PTZ-induced seizures in rats at different dosage. FUS reduced the spike and altered the EEG power. C-false positive neuron decreased and GAT65 positive neuron increased after FUS treatment. Meanwhile, AKT and TOR-H6 signaling pathway also reduced by FUS treatment. This result inspires us to consider FUS treatment in humans with epilepsy. We have to approve it is safe in humans first. What kind of patients, targets, and method for monitoring are suitable for the clinical trial? We have been thinking a lot of possibilities. We finally decided to study on patients who have finished the intracranial EEG studies with conclusive results. Before SEEG removal, targeting the planned resection region and monitoring IEEG, brain MRI, and clinical manifestation. Not like the other focused ultrasound system guided by MRI, we use NaviFus, which is guided by navigator system. The target and the trajectory are shown on the screen. The neurosurgeon holds the transducer and adjusts the position to fit the pre-planned pathway. We screen the patient first. Neuroimaging of the eligible cases will be submitted for plan and simulation. There were 2 cases not able to enter this trial for big head size and the distance between scalp and the target exceeding the limit of NaviFus. On the day of treatment, we shaved patient's hair and registered the navigator system. The parameter was according to our previous animal study. The first treatment lasted for 10 minutes. During this period, the patient was asked not to move. That is another 3-day IEEG recording after first treatment. 6 patients completed the study. The clinical characteristics were summarized in this table. 1 complained of heat sensation over the transducer contact scalp. 3 cases complained of localized pain over treatment area. For case 5, a functional neurologic disorder developed. The detail was presented in the oral presentation of the poster section. In our cases, no lesioning effect could be noted related to FUS treatment. We analyzed the power changes of the target electrodes during and after fast. There was a trend of increased power during sonication and reduced power after treatment compared to baseline. We put all channels together here, the cold color indicating reduced power, hot color indicating increased power compared to baseline. In these two cases, the majority of the channels show the reduced power from delta to beta band after treatment. In case 2, we have 2 data sets. The treatment duration of the first trial was 260 seconds, and the second trial was 600. The power changes during and after treatment were significantly greater when the treatment duration increased. Our conclusion is that focused ultrasound is safe and feasible in neuromodulation of a target region for drug-resistant epilepsy. Simultaneous intracranial EEG recording showed power changes during and after treatment. We encountered some difficulties in this trial, and there is space to improve. In our next steps, we will make some changes in the fuse treatment parameter, make a new transducer with larger dimension for approaching deep structures, and enroll more cases with well-studied C2 focus. I appreciated our team members and especially my patients for their trust and cooperation. Thank you for your attention. Thank you.
All right, I'm going to talk about some potential improvements we can have to ultrasound therapies for epilepsy by injecting microbubble contrast agents. As you may know, the current device that we have for ablation has a limited area that we can currently ablate in the brain. This is a diagram that may be out of date from Insight Tech, showing a probably conservative estimate of where they believe they can ablate in most patients. I mean, as you can see, it's fairly limited and excludes areas that we might want to target for epilepsy surgery, such as the amygdala, hippocampus. Right now we're sort of limited to thalamic areas in that vicinity. So one way we can enhance ultrasound and its effects is to inject a microbubble agent, and these are ultrasound contrast agents. And they respond very strongly to ultrasound, even at very low intensities, and they concentrate the mechanical effects of the ultrasound directly on the vasculature. We can use low intensity sonication to increase vessel permeability to deliver drugs. And for higher intensity sonication, we can shut down or break small blood vessels, leading to ischemia and alternative to thermal ablation. They also act as beacons that we can use to locate and quantify activity of the focus. And I'm going to discuss a few different ways that these might be helpful in the future for increasing our ability to treat patients with epilepsy. The first is just to improve the focusing itself through autofocusing. And this is from a study that was just published by the group in Toronto at Sunnybrook. And the concept here is we give a low dose of ultrasound contrast agent and iteratively pulse with different phase corrections. And we can use this and improve transcranial focusing. And what they found in trauma patients was that they were able to increase heating by 27%, and in a few patients were able to enable ablation in these patients where they couldn't achieve ablative temperatures without this autocorrective. So just by improving the focusing, it may increase the treatment envelope and allow us to target wider areas in the brain. We can also just use these mechanical effects of the bubbles alone as an alternative to thermal ablation. And the concept here is we give a regular dose of contrast agent, we apply the ultrasound, and we destroy the blood vessels, and we end up getting a lesion via localized infarcts. The main advantage of this is that the acoustic exposures are lowered by more than an order of magnitude, so we get no skull heating. We could, in principle, target anywhere in the brain with this approach. Our current challenge is we don't have the same MR thermometry feedback We only get heat a few degrees, which may be sufficient, but it's probably beyond the limits of what we can currently detect with thermometry. And so we need better ways to control and monitor this procedure. It's also a nonlinear process, so you get nothing and then all of a sudden you get a lesion, unlike in thermal ablation. So we need to figure out some of these control issues. But here was some examples. This is actually with the low frequency X-ablate system in a rat model. And we could see that we could very precisely ablate very small regions, even in the tiny rat brain. And one of the differences here is, since it's a ischemic volume, is that the tissue is removed very fast. So by 1 week, the tissue has been removed compared to thermal ablation. So this is potentially in the future a way that we could do epilepsy surgery quickly and anywhere in the brain. Moving on, we can also perhaps use these bubble agents to help with neuromodulation by delivering agents that affect brain function. So the concept here is we would disrupt the blood-brain barrier with ultrasound, image, and see where that is. And then by giving something like GABA, which will block function, we can get a temporary and localized functional block. The advantages of this are that we can block function at multiple targets or volumes simultaneously, and we know the mechanism and we can see where it's going to happen from MR contrast. And these are just some examples showing a reduction in somatosensory potentials from our group in this rat model. And finally, you can step this up and use the same approach instead and give a neurotoxin. This was an approach that came up with by the group in Virginia, and they were giving quinaloic acid, which is a neurotoxic agent, and by disrupting the blood-brain barrier and delivering this, you get very nice small lesions. This is, again, no skull heating, and this is perhaps a more neuron-specific ablation, thermal ablation. So to conclude, using microbubbles, we can improve focusing, enable ablation anywhere in the brain, and deliver agents to modulate neural function or selectively ablate neurons. But we do have questions on how to robustly monitor and control these procedures. So I'll stop there and thank you.
Got that.
Now let's turn our attention to all the panelists who are joining us for a discussion of our topics, which are far-reaching. We have 20 minutes to discuss these broad issues, and maybe we could organize our conversation around temporal lobe epilepsy, which is on everyone's mind, and then maybe some methodological considerations, then talk about neuromodulation. And in particular, I think a lot of people are asking that given the current technology, can temporal lobe epilepsy be treated by ablating the equivalent amount of tissue that interstitial laser thermal therapy is able to ablate? And this is something we've been back and forth about for a long time. And up until now, the answer has generally been we don't think so. So maybe we could start the discussion with Dr. McDonald and ask you to think if autofocusing with the microbubbles will allow treating the whole hippocampus, or maybe a more specific question is how low were the temperatures in rats with autofocusing compared to standard focused ultrasound?
So I haven't looked myself at autofocusing, which they've been doing in patient treatments. The results that I've seen are encouraging. They are getting more than 25% increase in the heating, but we do know that there's a huge variability in patients just from their skull properties. So it may be that we can treat temporal lobe epilepsy, but only maybe in a certain subset. But I think it needs to be worked out. I think that's something that's going to be coming over the next year are these first tests with autofocusing. With the other approaches I talked about, the heating, skull heating is not an issue, but using microbubbles themselves for ablation. But there are a lot of other challenges in that also. So I think the answer is maybe, and then we'll find out over the next year.
Yeah, it seems to be ongoing now, as you mentioned. Maybe I could ask Dr. Krishna or Dr. Ralston to comment on, think about using the currently available technology. I don't know that you've used autofocusing yet, but with the standard technology available today, what do you think?
The focus size, the focus size of the current system, the biggest lesion that we are able to achieve is say 6 to 8 millimeters. They are a little bit bigger in the SI dimension than AP or medial lateral. And we were discussing this, Dr. With Nathan before, that you would need 5 or 6 of these lesions to cover almost all of the hippocampus. And so with the current technology, I would think that the time would be a constraint, because every time you would move the spot, you would have to do the recalibration, initial sonications, and then. So with the current technology, I find it challenging. And this is also not considering the skull heating that would take place right adjacent to the target.
You think to add to that, Dr. Ralston?
So I agree completely. I think the major obstacles are the ability to get large volumes of tissue near the skull base, which we can't really do with the current system, which is why I think a lot of people are more interested in looking at nodes or tracks within the network that might be smaller and more tractable as targets.
Yeah, that makes a lot of sense. And so that takes us to thinking about the kind of targets that might be best. So far, we've been thinking about certain specific targets, but maybe could turn to Dr. Sperling to ask a question about things that seem to be particularly good targets or targets he's interested in, as he was mentioning in his talk.
I was wondering then about hypothalamic hamartomas, which are typically much smaller, as they strike me as within the bounds of the size that one could safely do, but the targeting precision, I guess, would have to be quite good, or else you could risk significant endocrine problems or hypothalamic problems. And also periventricular heterotopias would be another type of lesion if they're relatively discrete. So I guess I would ask my colleagues what they think about these 2 types of targets, the heterotopias and the small hamartomas, particularly in the hypothalamus.
Yeah, I can probably respond to that actually, because of an ongoing clinical trial we've had for some time. And you're exactly right in the middle of the brain, that's the best target. So HHs are perfect. They have certain other issues they may have other certain issues about their density and so forth, but the targeting and lesioning isn't a problem. It's almost the opposite, that it still takes a lot of lesions. You know, I think our problem in epilepsy and the nature of this whole temporal lobe epilepsy question, as relates to targets, is that the typical high frequency ultrasound we're using makes such a small target. It's a lot of targets to ablate a big area, which is often the lesions that are causing epilepsy. But you're right. So let me ask a little different question, Dr. Sperling, or to the whole panel actually. Can you imagine then a paradigm in the future in which we empirically treat lesions without intracranial monitoring, for instance? So right now, I don't think we just go ablate periventricular nodules with traditional therapies, because that would be pretty invasive. But imagine a non-invasive treatment like focused ultrasound, in which you think it's very likely that one of these nodules, assuming there's only a few, are causing the problem. Could you see a time where you just empirically ablate them and see if the epilepsy gets better? Maybe start with Dr. Fisher.
We've done stereotactic radiosurgery with CyberKnife at Stanford on 2 patients with periventricular nodular hyperplasia, one of whom had depth electrode recordings, and both of them got remarkably better. That actually surprised me a bit, because with PVNH, you have 2 areas of problems. You have the periventricular nodule, but you also have the distal cortex along the radioglia that didn't get its normal shipment of cells and can also be epileptogenic. So the limited experience, which was also, there was a series published in Pennsylvania on such cases, is encouraging, I think, in terms of the possibility of focused ultrasound helping.
So I guess that leads us to another idea that was brought up, a question from the audience. What about fractionated or incremental treatments? Because after all, it's at least conceptually easy to just have them come back for another non-invasive treatment. You know, it's for the patient, it's a big ordeal to come and sit in the magnet all day, but medically, it doesn't seem to be so much of an issue. So Dr. Sperling, do you have a comment on that?
Yes, I think it's a reasonable idea. It's something that we already do with thermal ablation, that we will deliver it, and on occasion, if it's not effective, rather than going back and doing a large open resection, we may try an additional ablation, and we've had success using that technique. So for something that's utterly non-invasive as opposed to a more minimally invasive with a thermal probe, I think that's a reasonable approach. Going back to your previous question also, I think it's absolutely reasonable to think about targeting small lesions non-invasively and lesioning them. We've Also, as Dr. Fisher said, we published probably 15 years ago 3 patients with periventricular heterotopias who we treated with Gamma knife, not as well focused perhaps as some of the other techniques, but still reasonably well focused. All 3 had been studied with intracranial electrodes. That all 3 showed seizure onset in the heterotopia as well as cortex, but lesioning the heterotopia made all 3 seizure free. And I now have more than 10 years follow-up in all 3. So I think there's little doubt that at least in some patients that can work. And I'm a big fan of doing something less invasive rather than more invasive. You can get away with it. So I think it's a reasonable thing to try if you can predict that the adverse effect is going to be minimal.
Michael, if I could follow up with a question to you on temporal lobe, since you and I have both done quite a few depth electrodes and grids in those patients, you really have to take the whole hippocampus, or is there a way to tell which part of it has to be taken that might be more amenable to focused ultrasound?
Yeah, I mean, the data is that you do not need to take the whole hippocampus. There are at least 2 published series where they showed that the extent of hippocampal removal did not correlate with outcome, although there's one more recent series that suggests maybe a little bit more posterior hippocampal inclusion does a little bit better. But certainly with a thermal ablation, the more anterior and medial ablations appear to be associated with better results than something that covers you more posteriorly. I think thinking about it as a hippocampal disease is a little perhaps too restrictive, should we say? And I think it's well known that when you need to include some amygdala within that as well. That there's often amygdalar sclerosis and maybe getting some perirhinal or entorhinal cortex as well. So I think the medial temporal lobe is potentially problematic for such a technique.
At least you could be incremental about it.
Yeah, you can be incremental. The issue is going to be how long, and it's really all technical and practical. How long does it take? How fast can you do it? And when you think, I have a talk that I give about device detection, and my last slide shows a picture of the Wright brothers flyer where they took 4 flights that day in December, and the last one was the long flight. It was 59 seconds. The first one was about 12 seconds, and now you can get an airplane in the hour for 19 hours. So I think with improvement in technology, which we can't even fully conceive, this focused ultrasound will become faster, more precise, and technical matters, and probably obviate that problem over the short term rather than the long term.
Dr. Krishna, were you going to add something to that?
Just one word of caution, I would say that when we are thinking about doing treatment in multiple sessions, the ability to heat tissue upon repeated prior exposures can be affected as well. And so something to keep in mind that the second treatment may not be as good as we were hoping before, or maybe it's better. In some cases, we have found in tremor patients when we retreat, if there is a cyst there, then the ability to increase temperature is much better because it heats much faster. But in a treatment, if we have done several treatments before, sometimes getting the temperature to therapeutic ranges is harder. And so having a previous exposure may affect the ability to have increased temperature later on. So something for us to study.
Temporal lobe epilepsy is the target, you might say, for surgery. And as a single group, I guess it is the single most common cause of epilepsy or location. But in fact, it still represents a minority, right? So most people have lesions that aren't in the temporal lobe, typically in the cortex. And that's the spot that's a little problematic right now. So we could turn our attention a little bit to thinking about outside the temporal lobes. We've been talking about that. And instead, think about more typical cortical epilepsies, which, of course, as we were just saying, takes you back on the methodological loop to find better ways to do this, which seem like they're maybe not so far in the future. And so the question is, would this be right for more cortically based lesions, or how far do you think we are, which is a little bit of a futuristic statement, which in some ways is easier, in some ways more difficult than the hippocampus. Dr. Ralston, do you have any comments or thoughts about that?
Yeah, so for thermal ablation, it's definitely doesn't look like it's in the cards anytime soon because of the difficulties getting so close to the skull and heating. But there's other technologies like histotripsy and other frequency regimes that we could operate in that might be more amenable to that. I think what's also exciting about that is once we get into these sort of more experimental therapies, we can look at not only using this therapeutically, but diagnostically. So back to your question about the heterotopias, it would be nice if we could not only, thermally ablate these, but also somehow test them beforehand to see how contributory they are with something like uncaging GABA or propofol, or something like Rog Aaron's doing at Stanford. There's a lot of potential for both diagnostic and therapeutic, which is really exciting.
I'd like to, actually, you mentioned Rog's work at Stanford, with which I'm collaborating. It's just fascinating, and I think it's worth just a brief mention. The idea is caging a drug in a polymer, and Rog is currently in rats, and I hope to do it in people fairly soon. It becomes inactive when you cage propofol, so you can inject it systemically. It goes everywhere, it does nothing. But if you then focus the ultrasound on the part of the brain that you're interested in, it cracks the polymer. The propofol goes within seconds into that part of the brain and keeps streaming in at that point, so long as you have the beam going. And it is a immediately reversible lesion, theoretically any place in 3D brain. As soon as you then stop the focused ultrasound, then with whatever kinetics the drug dissociation has, it will leave, but no more drug will go into the brain. So of course that's being studied extensively for chemotherapy, but I think it may have applications both in epilepsy for looking at nodes that might affect propagation of seizures, and also for the functional neurosurgeon to be able to see what the brain's going to look like acutely if you take that piece out.
The best WADA test ever.
Yeah, and again, the WADA test, we have to cover a pretty large area, so we have the same issue as temporal lobectomy, but theoretically, for spike suppression too, I think it can be interesting.
We've been working on a similar technique with disrupting the blood-brain barrier and administering GABA. And one of the nice things there is we can disrupt, multiple locations or volumes. So you could, open up the whole hippocampus at once, or the part that you think you can ablate. And you can administer GABA, and it blocks the activity for a few seconds, and then it comes back. And you can do that repeatedly as long as the barrier is open. And you could also use gadolinium to know exactly where you're modulating too. So there's, it's another approach that's very similar to what Rog's doing, which is very nice.
That's kind of a combined lesioning neuromodulation kind of a situation. So if we turn our attention to neuromodulation in our remaining minutes, maybe Dr. you might comment on how do you think we should define the targets for neuromodulation, however we do it?
When we started in our research, we have considered a lot of targets compared to the electric stimulation, like deep brain stimulation and ATN, or somewhere in the hippocampus. But finally, we think if we want to look at the immediate response, better to look into the intracranial EEG. The first step, we have no special target. Most of the cases, they have a focus that either frontal or temporal, then we focus on that area. I think that's also the advantage of focused ultrasound, because they can reach most of the deep structures. And we use the navigator system. I found it's quite easily, because I'm not a technique, but when I found the locus, I asked them to design a trajectory for me. And usually some trajectory seems very silly to them. But if we discuss together, it seems that you can get everywhere you want in the brain, except for the size of the transducer. Some are too deep. We need a bigger transducer. So maybe in the future, we need a different size of the transducer, and we can approach almost everywhere in the brain and focus on the region we want to modulate.
We do have a question from the audience specifically about exactly what you're talking about. And the question was sort of like you answered earlier: does the focused ultrasound beam cross the electrodes, and does that cause a problem for you? Which is, you answered a little bit earlier, but maybe you could elaborate on that. does it change what you can reach because the intracranial electrodes are in place?
I think that's all the problems we encounter in doing neuromodulation, not only for patients with epilepsy, also the normal subjects. Anything, not only the SEEG, even the skull, you enter that, you cannot truly 100% predict how the size or the angle or really the location you modulate. So in this, we adopt this method because the size and the energy is not so big and not so strong, and we are focusing on the areas that are going to be removed. So when you're regarding the safety and the feasibility, I think this is the first step we use this. But how to how to solve this problem of not so the reflection or the deflection? I think we need to find some way to make sure where the really localization we modulate.
Okay, so a
Would
more
second
broad
that.
question.
Sorry.
I'm sorry, go ahead, Dr.
I
McDonald.
would just say I would second that, and with neuromodulation in general. I mean, I think we're seeing a lot of feasibility studies, and it's very exciting. But we need to tackle the skull issue head on and really validate that we can actually predict that what we think is getting in the brain is actually getting there. Especially through some of the trajectories I've seen. I mean, we're doing a clinical study, and we're trying to go through the temporal window that they use for imaging to minimize the skull effects. But even then, we still are not sure what we're actually putting in.
I guess that's part of this whole dilemma we have between focused high intensity focused ultrasounds, highly precise, but is a relatively big ordeal, and low energy or low frequency ultrasound that's can do at the bedside essentially, but isn't as precise or confined. So I suppose it's the wedding somewhere.
And with ablation, we actually can measure what we're doing in the brain because we have the thermal maps, and we don't have that with neuromodulation. So.
Well, focused ultrasound surgery would be great, but focused ultrasound neuromodulation would be something truly new. It's only one case report, but that Abe study from Japan attempted lesioning, but could not get up to temperatures to do so. So there was no visible MRI change, and yet 1 year later, the patient was seizure-free and off medications. First case always seems to be better than subsequent ones, but that's extremely hopeful for neuromodulation.
Yeah, and I suppose that just as you're saying, it's different than other kinds of neuromodulations we've done for a lot of reasons. And so everything we've talked about sounds like great for the future. Thank everyone for participating. Hopefully we've struck some notes for the future as well. So thank you for your comments, and also thank you for joining us today.
Thank you.
Thank you.